Hi friends, today we will discuss about pathophysiology of muscle tone. This is little complicated and most important aspect of neurology. The outline of the topic will be the definition, spinal and supraspinal controls for muscle tone and various types of tone abnormalities. The traditional definition for muscle tone is the resistance felt by the examiner during passive stretching of a joint when the muscles are at rest. Whereas the clinical muscle tone is the constant muscular activity that is necessary as a background to actual movement in order to maintain the basic attitude of the body, particularly against the force of gravity. That is, the muscle tone acts like a construct or a framework over which the posture will be maintained, or it helps to have an active body movement. There are two types of muscle tones, postural and phasic. Postural muscle tone is the prolonged muscle contraction due to steady stretch on the muscles and tendons. And here the gravity is the main inciting factor. Whereas phasic muscle tone is the rapid and short duration response in response to rapid stretching of the tendon and attached muscle, the more precisely muscle spindle. It is assessed clinically in the extremities. The passive tone and active tone are the two types of muscle tones which are normally assessed in the newborns. Passive tone is the extensibility of muscles when child is at rest. Active tone is nothing but active movements of the infant in reaction to certain situations imposed by the examiner. The examples for passive tone are scarf sign in the upper limbs, adductor angle, popliteal angle in the lower limbs. Whereas the examples for active tone are pull to sit maneuver, ventral suspension and prone suspension. Let us see the basic neuroanatomy of muscle spindles and Golgi tendon apparatus. So muscle spindles are nothing but the intrafusal fibers. They help in sensing the muscle length or rate of change of length. Whereas Golgi tendon organs, they are located in the tendons and they help in sensing tendon tension or rate of change of the tension. The type 1A fibers help in detecting the rate of change of length of the muscle spindle, whereas type 2 fibers help in detecting the steady state length of the muscle. Similarly, type 1B afferents send the information from the Golgi tendon organs relating to the tension in the tendons. So here we can see the muscle spindles are of two types: nuclear bag fibers, nuclear chain fibers. The central portions are supplied by the 1A and type 2 fibers. As we already discussed, 1A fibers help in sending information about the change of length of the muscle spindles, whereas type 2 fibers sends the information regarding the steady length of the muscle spindles. Here the ends of the muscle spindles, you can see they are composed of striated muscles. So the only ends of the muscle spindles can be contracted. So the gamma efferents are supplying the ends of the muscle spindles. Once these gamma efferents are activated, the ends of the muscle spindles gets contracted and the central portions of the muscle spindles will be stretched, so that this 1A fibers will be activated and sends the information regarding the length change of the muscle spindle. Similarly, here you can see the group 1B afferents are supplying the Golgi tendon apparatus, which are located in the tendons. So the change in the tension of the tendons will be sensed by the 1B afferents and sends the information through the dorsal horn to the spinal cord. So this is the main framework how the spinal control of muscle tone will be happening. So initially the gamma fibers, once they are activated, they help in the contraction of the ends of the muscle spindles. So as we have seen in the previous slide, once the ends of the muscle spindles are contracted, the central portion of the muscle spindle will be stretched. Thereby 1A fibers get activated and sends the information regarding the change in the length of the muscle spindle. So in relation to that, it will activate the alpha motor neuron. Once alpha motor neuron gets activated, the extraphyseal fibers will be contracted. This is the basic loop of the muscle stretch reflex. So once again, once these gamma fibers were activated, the ends of the muscle spindles will be contracted so that the central portions of the muscle spindles will be stretched, thereby activating these 1A fibers which enter the spinal cord through the dorsal horn and activates this alpha motor neuron. Thereby, this alpha motor neuron stimulates the extraphyseal fibers and help in muscle contraction. So, what are all other neurons which help in controlling the muscle tone at the spinal level? So, this is one area where there will be continuous presynaptic inhibition at the level of activation of the 1A fiber, at the level of the activation of the alpha motor neuron through 1A fiber, and other negative signal or inhibitory signal to the alpha motor neuron is through the 1B fiber. As we have already discussed, this 1B fiber sends the signals through the Golgi tendon apparatus, which will sense the change in the tension of the tendon. Similarly, the antagonist muscles will also send inhibitory signals through the 1A fibers, thereby inhibiting this alpha motor neuron. So apart from this spinal level control of the muscle tone, there are different supraspinal level controls. So let us see the basic anatomy. So here it is the motor cortex, which is just anterior to the central sulcus, and anterior to the motor cortex there will be premotor cortex and supplementary motor cortex. So Broca's area for motor cortex is 4, the supplementary motor cortex and premotor cortex Broca's area is 6. Similarly, in the midbrain, the red nucleus helps in controlling the muscle tone, and at the same time the reticular formation, which are vertically located nuclei in the brainstem. So they are located in the median region, paramedian region and lateral region. So here you can see this reticulospinal tracts arising from the pons and medulla. The pontine reticular formation will have a intrinsic stimulating activity over the gamma motor neurons, whereas medullary reticular formation forming the dorsal reticulospinal tract won't have its own intrinsic activity, so they will be stimulated by the contralateral corticoreticular tracts. So once it is activated by corticoreticular tract, this dorsal reticulospinal tract will inhibit the gamma motor neurons. So here you can see from medullary reticular formation, dorsal reticulospinal tract will come and will inhibit this gamma motor neurons, whereas from pontine reticular formation, this medial reticulospinal tract will come down to the spinal cord and will have a stimulatory effect over the gamma motor neurons. Similarly, from lateral vestibular nuclei, that is Dieter's nucleus, the vestibulospinal tract will come and it also stimulates the spinal level muscle tone but here this vestibulospinal tract doesn't stimulate the gamma motor neuron, but it will have a direct effect over the alpha motor neurons, and we will see how it affects the tone in later slides. So in this image we can see the rubrospinal tracts, which will also have supra level, which will also have a higher level control from the motor cortex, which is nothing but the corticorubral tracts. So in this slide, even though it is slightly busy, but it is very easy to understand. These are different levels of the brainstem. This is medulla, this is pons, and this is midbrain. As we have already shown the basic anatomy, which are all controlling the muscle tone, it is very easy to understand in this slide. So motor cortex and premotor cortex, from where this cortico-reticular tract is arriving, and this is midbrain, where this red nucleus will be there, and pons, where the reticular formation nuclei, from which this medial reticulospinal tract is arising, and in the medulla, from reticular formation nuclei, the dorsal reticulospinal tract will be arising from the medulla. As we have already discussed, this medial reticulospinal tract arising from the pons will have intrinsic stimulating activity over the gamma motor neurons, whereas the dorsal reticulospinal tract arising from the medulla will get a stimulatory effect from the corticoreticular tract, and in turn it will inhibit the gamma motor neurons. Similarly, from the red nucleus, they will have a reticulospinal tract, which will have a more impact over the alpha motor neurons than the gamma motor neurons, and that too, these reticulospinal tract supply flexors of the upper limbs, not to the lower limbs. Why? Because the reticulospinal tract will be ending only up to the thoracic level, not beyond that. Similarly, in the medulla, we have a lateral vestibular nucleus, that is Dieter's nucleus, from which vestibulospinal tract will be arising and which will be stimulating the alpha motor neurons. And this vestibular nucleus will have a higher control from the cerebellum. So here we will see the Sherrington experiments, which he has done in cats in 1898. So what he has done, he has made a transection at the level above the midbrain. So where this red nuclei are spayed. So you can see this red nuclei are located at the level of the superior colliculi. This is the dorsal view of the brainstem. This is the midbrain, where you can see the superior colliculi and inferior colliculi. At the level of the superior colliculi, this red nucleus will be present. So once you transect at the level above the midbrain, where the red nuclei are spayed, we will see decorticate rigidity. So decorticate rigidity means the upper limbs will be in flexured position and lower limbs will be extension position. The only reason why upper limbs were going into flexured position is due to red nuclei. As we have already discussed in the previous slide, the rubrospinal tract, they will supply the alpha motor neurons and only up to the thoracic level. So that is only in the upper limbs the flexor muscles are supplied by the rubrospinal tracts. Due to this effect, in decorticate rigidity, upper limbs will be in a flexed position and lower limbs will be in the extension. So here in decortication, midbrain is spayed, that is red nuclei is spayed, but we are losing the corticoreticular tract. So once this positive effect of the corticoreticular tract is lost over the dorsal reticulospinal tract, the inhibition over the gamma motor neurons will be reduced. Thereby the net stimulation by the medial reticulospinal tract will be increased, resulting in increased tone. And also, as red nucleus is being spared, the upper limbs will go into the flexed position. So this is the basic mechanism for the decorticate posturing. In decerebrate posturing, the transaction is done at mid-collicular level. So in between the superior and inferior colliculi, transaction is being made. So the rubrospinal tracts will also be transected. So the upper limbs, which mainly get these rubrospinal fibers and the two to the flexor muscles of the upper limbs, will be lost. As the influence of red nucleus is lost, the net effect this medial reticulospinal tract will be more predominating and result in extensor posturing in both upper limbs and lower limbs. So in decerebrate posturing, we are losing the effect of both corticoreticular tract and rubrospinal tract. So the net intrinsic facilitatory activity of medial reticulospinal tract will have increased stimulation of the gamma motor neurons and result in increased tone. So in this picture we can see in decorticate posture the upper limbs will be adducted at shoulders and flexed at the elbow and flexed at the wrist and the fingers, whereas in the lower limbs they are internally rotated at the hips and extended at the knee joints and plantar flexed at the ankles. In decerebrate posturing, in the upper limbs there will be adduction at the shoulders and extension at the elbows and pronation at the forearms and flexion at the wrist and the fingers. In the lower limbs, the posture will be similar to that of decorticate posturing. So another experiment which is done by Pollock and Davis in 1930, he created a ischemic decerebrate posturing. He has done by ligating the internal carotid arteries and the basilar artery at the lower margin of the pons. Thereby, ischemia happened in both cerebral hemispheres along with the pons. Apart from pons and cerebral hemispheres, both cerebellar hemispheres also got affected. So with this, the influence of cerebellum over the vestibular nuclei is lost, thereby causing decerebrate posturing. Here, even after transecting the dorsal roots, the rigidity is not lost. Thereby, you can know this rigidity is due to alpha rigidity, which is not dependent on the 1A afferents. Whereas in decerebrate and decorticate rigidity, the major effect is due to medial reticulospinal tracts, which is having predominant effect on the gamma motor neurons. So once these gamma motor neurons are having intrinsic hyperactivity, they tend to contract the ends of the muscle spindles, thereby stretching the central portion of the muscle spindles and activating the 1A fibers. This 1A fibers in turn activate the alpha motor neurons and causing the muscles to contract. That's why in decorticate and decerebrate posturings, due to intrinsic hyperactivity of the gamma motor neurons, these alpha motor neurons are indirectly activated and causing the increased muscle contraction. So once we do dorsal rhizotomy in decerebrate or decorticate posturing, we are disconnecting this feedback from the muscle spindles through which is going through the 1A fibers. Once 1A fibers are disconnected, there won't be activation of the alpha motor neurons. Thereby, increased tone will be lost in case of decerebrate and decorticate posturing whenever you do dorsal rhizotomy. But in ischemic decerebrate rigidity, what is happening is here there is an increased tone due to vestibulospinal tract overactivity. This vestibulospinal tract will activate the alpha motor neurons directly. Thereby, there won't be any increased afferents from the 1A fibers from the muscle spindles. So, even though you do dorsal rhizotomy, it won't affect the muscle tone as it is due to direct activation of the alpha motor neurons from the vestibular spinal tract. So here you can see even the medial spinal tract which is coming from the medial retrospinal tract which is coming from the pons is got affected when you do this ischemic procedure by ligating the basilar artery and internal carotid artery. Thereby, the only descending tract which is activating the spinal level motor neurons is vestibular nuclei. That too, this lateral vestibular nucleus which forms this vestibulospinal tract. This directly activates the alpha motor neurons rather than the gamma motor neurons. That's why in case of this ischemic decerebrate rigidity, the dorsal rhizotomy doesn't affect the increased tone. The increased tone will persist even after dorsal rhizotomy in case of ischemic decerebrate rigidity. In case of spasticity, why we see clasp knife phenomenon? So clasp knife phenomenon is nothing but the more resistance is felt in the initial part of the stretching. With continued stretching, a sudden release of the resistance occurs. We know spasticity is a length dependent phenomenon. So when the quadriceps muscle is in a contracted position, when you try to flex the knee, so when the muscle is contracted or when muscle is short, you will feel the increased resistance. Once you keep on stretching the muscle by knee flexion at one point of length, the resistance will get released. That's how you feel the clasp knife phenomenon. Clonus. Clonus is the regular repetitive rhythmic contractions of a muscle subjected to sudden and maintained stretch, and only if it sustains for 5 or more beats it is pathological. We will see the presumed mechanism of clonus. So there will be intrinsic hyperactivity of the muscle spindles which causes activation of all motor neurons from the burst of impulses coming from the spindle, that is through the 1A fibers will stimulate the alpha motor neurons and cause this contraction of the extrapyramidal fibers. That consequent muscle contraction stops the muscle spindle discharges. During maintenance of the sustained stretch, the muscle is again stretched as soon as the muscle relaxes. So again the spindles are stimulated. That's how this clonus will be sustained. Coming to rigidity, here it equally affects both flexors and extensors. And there are two types of rigidity, lead pipe rigidity and cogwheel phenomenon. And the cogwheel phenomenon is nothing but there will be a superimposed tremor or an underlying not yet visible tremor over the lead pipe rigidity. This intermittent increase in tone during passive movement will happen whenever there is a superimposed tremor, thereby giving this cogwheel phenomenon. So these are the basic differences between spasticity and rigidity. Spasticity is velocity dependent. Only if you do at a rapid passive stretching of the muscles, you will feel this spasticity. Whereas in rigidity, the rapidity of passive movements doesn't affect your resistance. And also, spasticity is length dependent. When muscles are at a shorter length, or when muscles are in a contracted phase, you will feel the more resistance, and once the muscles are stretched, the resistance will be lost. Whereas in rigidity, the resistance will be equal at different lengths of the muscle. Similarly, the type of tonicity is clasp snap, as we already discussed in spasticity. In rigidity, it will give either lead pipe feel or cogwheel phenomenon. And at the same time, spasticity will give the resistance more in one direction than in the other direction, whereas in rigidity, the resistance is equal in both directions. So another abnormal muscle tone phenomenon is dystonia. Dystonia is a sustained or intermittent muscle contractions resulting in abnormal, often repetitive movements, postures, or both. And often they are all patterned movements. They will have a tremulous or twisting nature, and normally they will get aggravated with voluntary action. Two characteristics of dystonia are mirror movements or gesti antagonistic. What are mirror movements? Expression of motor overflow in dystonic patients. That is abnormal posturing in the affected limb induced when the contralateral unaffected limb is engaged in a specific task. We will see one example in the next slide. What is gesti antagonistic? These are sensory tricks normally present in patients with dystonias. So once they touch the portions which are affected with the dystonias, the intensity of dystonia will reduce. So here you can see this child is trying to hold the book in the right upper limb. At the same time, you can observe the similar muscular contraction in the left upper limb also. So other higher level dysfunction in muscle tone is paratonia. It is defined as the increased muscle tone in response to passive movement proportional to the strength of the stimulus applied. So the degree of resistance depends upon the speed of the movement. If the speed of the movement or the intensity of the stimulus is high, the resistance you feel will be high. If the speed or intensity of the movement or passive movement is low, you can't feel the resistance in terms of paratonia. There are two types of paratonia, whether it is oppositional or facilitatory. Oppositional is called as Geigel-Hamilton and facilitatory paratonia is called as Medgehen. So here, similar to spasticity, it is speed dependent, but paratonia is equal in both directions, whereas in spasticity it is more in one direction than the other. So that is the basic difference between spasticity and paratonia. And other thing, even though it is equal in both directions, similar to rigidity, it is in rigidity it is independent of the speed of passive movement. Even though you move the limb passively at a very low speed, you will feel the same resistance. Even at a higher speed, you will feel the same resistance in case of rigidity. But in paratonia, the resistance what you feel will be dependent on the speed or intensity of the movement. That's how paratonia can be differentiated from the spasticity and rigidity. So these are two tests which can help us to assess for paratonia. So one test for oppositional paratonia, that is called limb placement test. Here we'll passively lift the patient's arm above head, instructs to relax and then release the arm. If the arms remain aloft in the absence of Parkinsonism, that is in the absence of rigidity and spasticity, it is nothing but paratonia. Whereas in Kral procedure, It helps in assessing the facilitatory parotonia. So we'll instruct the seated patient to relax, and then we'll passively flex and extend the elbow several times, and then release the arm at the level of the thigh. Even after releasing the arm at the level of the thigh, there will be continuous cycles of elbow flexion and extension which will continue for few cycles. This is due to this facilitatory parotonia. So this test is called as Kral procedure. Hope everyone understood this basic pathophysiology of muscle tone and different abnormalities in the muscle tone. Thank you.